Hello, and thank you for coming to our podcast, Senior Spotlight for Concierge Care Advisors. And this is podcast number 6. I'm Mary Cordova. I'm the EVP and co owner of Concierge Care Advisors. We help seniors find housing and help them stay at home safely with in home care. Today, I am with two doctors from our physician board, Dr. Moraes and Dr. Ferris. Welcome.
Thank you.
Thank
Go
you.
ahead and introduce yourself, gentlemen.
Go ahead.
I'm Dr. Alex Moraes. I'm a family practice physician. I also am the medical director of a hospice organization and in nursing homes, and I've been in medicine for 27 years.
Perfect. Right down our alley, that's for sure.
My name is Dr. Brian Ferris. I am a vascular surgeon and general surgeon. I've been in practice in the area for over 20 years, fellowship trained, and happy to be here.
Great. Thank you again, doctors. Appreciate you having us. You coming to be with us. And I just wanted to talk about the importance of involving seniors in the care decisions. And I think it's important on your side, on the medical side, of course, but on our side, of course, not to make decisions for someone, but more importantly, with them. And from the hospital room, that's not always something we can do. So hopefully people are preparing in advance to that hospital stay. But really want to talk about on your side on how much do you share with the families, how much do you share with the seniors, keeping them involved. And I think Dr. Moraes, on the hospice side, that's something that we see that perhaps people are not sharing enough at physician level.
Mm-hmm.
And then they come to us and say, gosh, mom hasn't been eating for 3 or 4 days, and there definitely is a failure to thrive and heading that direction. And it's an uncomfortable conversation for my staff to have. And I don't think we should be having it as much as we do have it, because we introduce hospice, of course, when we think that it's applicable. But can you talk a little bit about bringing that up to the seniors, having that real frank conversation with the seniors and their families about some of that?
Absolutely. We've gotten used to having, for example, our advanced directives, which talk about what we want done if something happens to us. Unfortunately, that really applies way downstream from the moment that we get sick or ill. There is it's different in Washington than California. In California, it's called a POLST, P-O-L-S-T, which is what you want done if something happens to you immediately. I use that tool as a conversation with my patients starting at as early as 40 and 50 years of age, because it begins the thought process of what do I want done if something happens to me? What are my wishes in the future? What if I get ill and have an accident? But that conversation also extends itself to their family members, because now they take it home and have a conversation with mom and dad. What's challenging at times is that I have to be able to tease out of my patients what they really want, because sometimes they'll just defer to the family.
Right.
And the challenge at that time is if you have a larger family of 2 or 3 people, sometimes there's not a designated power of attorney, or they prefer to share it, which makes it really challenging when something happens. What I've also found in especially in the United States is we don't like to talk about death.
Yeah.
We don't like to talk about illnesses and what happens to us. We don't want to talk about where we want our remains to go after we pass. And we really don't want to set those plans in motion if they occur. We see that especially in hospice, and you've probably seen this in the hospital at times when outcomes don't go the way that we expect, or somebody is there when they really have a significant illness, is we think of hospice as when we're going to die, but hospice should be introduced before that, when you still need support.
Right.
When you have an illness that may be terminal, because many times, like I mentioned before, I've seen people rally out of hospice and recover with the additional support because they have a team around them. So the conversation it's a big conversation. Sometimes it has to be had, for me, over 2 separate appointments.
Sure.
And many times an hour doesn't do justice in that conversation. And there are many physicians who have shorter time appointments, 15, 20, 30 minutes, And it's just a subject that many people don't like to broach because it occupies the whole time. And it's always introduced in the middle of something else, right?
Right.
In the middle of a cold, or in the middle of an illness, or in the middle of somebody having heart failure. And those conversations should have occurred way before that happened.
Yeah, I completely agree. I think that part of the challenge, and there's lots of challenges, I think, as I was reflecting on your conversation and hospice, people think of cancer. Unfortunately, it's not just cancer. It's the neurodegenerative conditions. It's cardiovascular diseases. In my world as a vascular surgeon, all my patients with arterial disease by default have heart disease. They also have arterial disease, and they represent an interesting part of the population, in that often they come to us undertreated for some things, and so we have the privilege of seeing a wide spectrum, and we can put numbers on it. And when somebody has reduced blood flow to their leg, that blood flow reduction is linearly proportional to their survival. And so by default, the conversations in an arterial practice, a peripheral arterial practice, become a little bit easier, because you start edging up against that. And when I was in medical school, and I believe we've talked about this before on prior podcasts, there was a big push and a big wave of advanced directives, and I think we've kind of taken our foot off the gas pedal for that. And in Washington we have advanced directives, but we really put the emphasis on POLST, and that's fine as the airbag, but I think it's not just the seatbelt, but it's also using it as a segue to have that conversation earlier. And so in my world, on a more elective, not emergent basis, it becomes a little bit easier because it's part of the next steps as what if. On the other hand, when it's an emergency, it is totally the wrong time, and it's very, very difficult. And the systems are now mandated to try and push it, and so on and so forth. And in fact, we have a personal friend who they're in their early 80s, and they live at home, and they're independent, and so on and so forth. And they haven't had these conversations with their primary care physician, let alone any physician, nurse practitioner, or PA. But the health system itself sent them a mailer about it, which is great intentioned, but somewhat atonal.
Yeah.
And fortunately, they weren't upset about it, and they had a resource to ask some questions, but they were, if anything, confused, not because they didn't understand it, but why is this being sent to me along with the grocery store coupons?
Exactly.
And so well-intended, but
not very sensitive.
Out of place, whereas I think, as Alex said, there needs to be value for that time, because you can start helping prevent problems. And right now we're so congested with acute decompensations of chronic problems, it's a great way to start biting into that.
If you look at any successful business, they have a team, right? It's almost impossible to become a huge organization. You name any company, right, on your own. They have a team. And what we unfortunately don't look at is the teams that are around us and how we can bring them into play. And for me, for family members, I try to explain to them, anytime you see your loved ones or even yourself and you say, boy, I could use some help, that's the time to call, Concierge Care Advisors. It's the time to maybe call hospice. It's the time to contact your physician and get home health services involved. Because what happens is that sometimes that team changes the outcomes in a very positive way.
Right.
It's not the beginning of the beginning of the end.
Yes.
It might be the beginning of the turnaround that changes that person's life for the better and gives them an advanced quality of life for a period of time. And we just haven't locked into that. And it's a switch that many people are fearful, because when they bring on a team, they think it's now and I'm going to use hospice as an extreme. When they bring on
Right.
hospice, it means that mom and dad are going to die. It doesn't mean that.
Right.
It means that you now have support that allows you to be the family member and not the caregiver
Right.
anymore.
It's almost like a lifeline.
Yeah, it
More eyes and
changes.
ears.
It changes your relationship with your family completely, because you're not. You have somebody now doing the work, and you're there to support them emotionally. It's really cool. It
is
changes
really
the
cool.
dynamics 100%.
Well, and I think that that's, again, part of my own attraction for joining with Concierge Care Advisors is to know that there is more of a coordinated effort. And if we're all working from the same perspective and in alignment, I think it's a force multiplier for me. It, I think, is much more calming for that individual or their family, and that's incredibly powerful.
To have a lifeline of someone that knows how to navigate and have these conversations. And if we think someone is failure to thrive or needing to have that conversation about hospice, we can get a hold of hospice and they can articulate that message, not us. And I think that's very helpful. You mentioned home health, and I think home health is underutilized in the home setting, where we could really bring that in much earlier. And everyone that transitions that we place into assisted livings, adult family homes, or memory care also can transition with home health under a new environment label.
Yes.
And so I think that is huge. And someday I think you should do bedside manners for physicians. I'm sure you've been told that before.
You're trying to get me in trouble here.
Well, you know, it's on the way over. Alex and I were just talking about that.
Actually, we were.
There was a reinvention of the wheel clinical study where patients and families were surveyed after a physician encounter, and the principal variable was whether the physician sat or not.
Oh.
And they moved the chair, or there was no chair, how close was the chair. And if I recall right, something very similar was done a long time ago when I was an itsy-bitsy little medical student. And it turns out and that's what was part of the teaching.
Felt connected.
Is that connection. And I think the underlying theme to everything that we're talking about is time. Mm-hmm. And we're all short of it, and there's a lot of pressure and a lot of need, and you have to take a team approach to really utilize the time properly. But it doesn't take much time to sit, and I think that's valuable for anybody when you're having these types of conversations, no matter who you are on that team. For that individual, when they're in need, that's a massive gesture that I think transcends most other whether it's from a cultural standpoint, social standpoint. You're taking that time, even if it's not a measurable difference in time, it's a gesture that's very, very powerful.
Getting to know them better, getting to connect. Same with when we take them to an assisted living. We don't walk through the door and show them the common areas in an apartment. We sit and let the marketer ask questions and get to know the senior and their family that we have brought into their community. Doctor, you were
There was
gonna
one
add to
little
that.
study that said if you sit and don't say, just ask a question, how may I help you today? Most people will run out of something to say in about 90 seconds. They'll say everything, but if you interrupt them repetitively, it takes multiple minutes to get to the point.
Much more time.
So just sitting and listening is it's extremely important.
Importance of early discussion and really taking that time to
One of the
listen.
things that I wanted to mention is people are fearful of costs of services. They're like, I can't afford it, or I don't want to spend it, or I don't think it's worth it. And the models of pay for different organizations are different based on your insurance, but many services are either covered or partially covered. I really appreciated your model of care when we first joined, because your intent was really to care for the person and provide them the best level of service, because you have no vested interest to not treat or not take care of them.
Right, right.
You're really engaged as much as you can.
I had a call actually from the hospital before I came today, and they said, can you set up transportation for someone that needs inpatient surgery and just needs a sitter, and then someone to transport him back home? And absolutely. And they're like, well, how do you get paid? And I said, we don't get paid unless we place somebody and transition someone into assisted living or adult family home. This is something we just do for clinicians. So you're not calling 5 different people to get transportation set up for someone that needs inpatient surgery. And she just couldn't believe it. She was like, oh my gosh, this is amazing. So I think you're absolutely right. And as Mark would say, we're kind of the best kept secret, because we are free.
You really are.
We can help with home health. We can help with hospice, going and doing the home visit. And sometimes it's just sitting down with the family members and their seniors and talking about what's important to them. Having that conversation, like we've talked about, including the senior when applicable. I will tell you there are times when people have late stage Alzheimer's, and we know having a conversation is just going to bring up that anxiety level. So sometimes you're making decisions for them, not always with them, but of course, if they're alert and oriented, they should always be part of that process and part of that subject.
Agreed.
I like it. We all want a personal assistant.
Yes, exactly. I met with Kaiser late last week, and their recidivism rate, which for people that don't know what that is returning back to the hospital after a discharge. And their recidivism rate in the last 2 years have really increased.
Sure.
And they obviously are trying to find out what to attribute that to. And what I would like to know is how many of them were giving a free senior advisor to be able to navigate that. And I think that's a measurable thing that they could measure to say, gosh, you know what, you're right. Only 30% of the people went home with an advocate free like you guys. Whether it's Concierge Care Advisors or a competitor that lives locally that's going to get in their car and go out with you, not a .com that's just going to talk to you over the phone, really changes the outcome of the success of a senior and their next journey.
It does, and I believe from my point of view in my practice, what I see is from the nursing home perspective, I used to see a discharge, go see Dr. So-and-so, but there was no preset appointment, right?
Oh, right.
And even now, for example, if somebody's has gone in for a TIA or a stroke, follow up with a neurologist. In my town, it's a year wait to see the neurologist.
Oh, wow.
So, and the hospital is not making an appointment with them; they're just discharging them to go see the neurologist. So hence, they go home, they can't see the neurologist, they get a headache, they go back to the emergency room.
Right.
So we're creating this revolving door process because it's multifactorial. Obviously, there's a shortage of care providers in the United States, but also the way that we're helping people along the path to care. We're not assisting them. We're just saying, okay, I'm going to do this. See you, bye.
Now it's on you. Yeah.
Now it's on you.
Right.
But if you have an advocate, that advocate can work for you and make sure that you may not be able to see that specialist, but at least they'll get you to your primary physician, who can now at least assist in the process and maybe keep you out of the emergency room. Because we know the studies, every time you go back and you get hospitalized for a day or two, your health declines a little more each time, and the recovery is so much harder.
So much harder.
I think, sadly, that we're at a setup for that to grow worse, because the demographics are, we have a shortage of a lot of things, physicians, nurses, etc., hospital beds, but we also have an aging population, and there's a lot of age-related comorbidities. And so I'm not surprised to hear you say that they're not only seeing a bump, but they're not really sure what's going on, because it is multifactorial. And that's where I think you have to retreat to that pre-acute phase. And that's, again, when we talked early on about where's the alignment with Concierge Care Advisors, and from a health perspective, things like the basics of, you don't just have a discharge paperwork saying go see this doctor, but that advocate, or whether the system took it on, they're setting you up with an appointment, right? There's an appointment, and they're depending on which corner or office or rule you look at, maybe from a Medicare perspective or whatnot, that should happen. But in But in effect, it's difficult. There's just not enough slots and not enough specialists or primary care and anything in between. And so when that is set up ahead of time, you can help try and impact minimizing or breaking that cycle, because it creates its own weather, which makes even more shortages and just feeds the fire. And so I think that's vital to address.
Well, you two are the ones that really brought it to our attention to help with the PCP follow-up after a hospital discharge. We know that that is a reason for recidivism, along with some medication if you're getting a 3-day supply and it's on a Friday. So you guys helped change our policy around that, which has been great. We write right on the tour guide for the family members when the senior's PCP visit is, and hopefully we're, making a difference there.
That's a great
At
start.
physician level. Yeah. So we love that you guys look over our processes and can add so much added value from your expertise.
And I think technology is going to help with that because of the ever increasing reliability and sophistication of telemedicine to check in and so on and so forth. But of course, the difficult link is that elder individual is probably going to be the least technically sophisticated.
Right, savvy.
Maybe the highest acuity person is not going to have access to what they already know, or if they even have those basic technologies for their cell phone or so on and so forth. And so many times in my own practice, well, did you look at your Medicare supplement insurance, their website, their app, to see what services? And
no, it's overwhelming.
they've never done it.
No,
They don't
no.
look. No one looks.
Yeah, even their long-term care policy. I spend a good chunk of my day looking at people's long-term care policies. And some of them are written, 35 years ago. Of course, they have no idea what it covers.
Yeah.
And 35 years ago, we didn't have the assisted livings and the adult family homes and things that we have. Sometimes it's just written as a nursing home writer. So, it's overwhelming.
Right.
So getting an advocate is absolutely a blessing to these seniors. Thank you again, doctors, for coming back to the podcast.
Absolutely.
This
Thank
is
you.
Concierge Care Advisors, and you can reach us at www.conciergecareadvisors.com. Thank you.
Thank you.